Good afternoon. We're going to start the live case and lecture number 2, which is TAVR. And I think we have a few more panelists going to join us, but I'm going to get started because of time. I'm Alan Yung, and my co-moderator is Grube. I'm sure he'll be here in a minute. And our panelists include Dr. Bapat, Dr. Chiam, Dr. Cohen, Dr. Finn, Dr. Hayashida, Dr. Hildick-Smith, Dr. Kapadia, Dr. Kubo, Dr. Lee, and Dr. Yin. So let's go to Asan Medical Center for the case number 3, which is going to be first operator is Dr. Duk-Woo Park. Hello,
Okay, hello, how are you? Good afternoon, everyone. Okay, and thank you for joining the TCTAP 2023, and we start the first live for TAVR case, and we prepare the very interactive and discussable the TAVR case. So further ado, I'm gonna introduce our team. I'm D.W. Park, Asan Medical Center. And the first assistant is Dr. Gossadi from Saudi Arabia. And the second assistant, our senior fellow, the Yung-Tsai. And also, the structural heart intervention team, ECHO co-rep director, Dae-Hee, Professor Dae-Hee Kim, and he's echocardiography specialist. And the reason why there is some reason to invite the echocardiographic specialist in our live case demonstration. Okay, Dr. Gossadi, can you present the patient background?
Okay, thank you. Our patient today is an 80-year-old female with a history of diabetes and hypertension. She has recurrent admission to the hospital with a history of shortness of breath, class 3 and 4. And echocardiography showed low flow, low gradient, severe AS with severe LV dysfunction. Past medical history are remarkable. Next. Mass body index is 21. STS score is 8.9, and Euro score is 2.7. So our patient is high risk. Next. ECG showed non-specific changes. Next. A chest X-ray showed some calcification arch of the aorta and cardiomegaly. Next. A coronary angio was done 2 months ago, and it was showed a normal coronary artery. Next. Echo showed LV function 35%, aortic valve area 0.69 centimeter square, peak to mean gradient 24 to 12. And Vmax is 2.5. Annulus area, annulus diameter is 18.9. Stroke volume 30 ml, and the stroke volume index 22.6. And there is RV dysfunction with mild resting pulmonary hypertension, with moderate TR and mild to moderate MR, with minimal pericardial effusion. Next. CT analysis at the level of annulus showed a short diameter 19.8 and long diameter 25. Area is 397 millimeter square, and parameter 71.6. Next. Sinus of Valsalva area is 708 with the sinus to annulus ratio 1.7, and ST junction area is 600 with the ratio of 1.5. Next. LVOT area is almost 400 with the ratio is almost 1. Next. Calcium score is low, total score is only 48. Next. This is actually there is some calcification at the level of the arch of the aorta, and as you see, there is a low calcium on the aortic valve. Next. Coronary height, left main is almost 12 millimeter, RCA 18, so there is a low risk of coronary obstruction. Next. This is angio of the peripheral iliofemoral arteries, and it showed visibility, good visibility for femoral approach. Next. Sizing chart for Evolute Pro, as you see, at 26 we can get oversize 14%. So we'll choose 26 Evolute Pro. Next. And this is coronary view. Next. So in summary, our patient is 80 years with severe aortic stenosis, low gradient, low flow, high risk patient. Planning to do 26 millimeter oblute with right femoral approach.
Okay, Professor Kim, can you go ahead at the explanation from some important echo finding?
Yeah, this is Dae-Hee from Asan Medical Center. This is a transverse echo image showing depressed LV. Every chamber was not dilated. You can clearly see the opening limitation in aortic valve and flow acceleration, and the moderate degree of function MR was noted in this patient. Next. In short axis image, you can clearly see opening limitation of a three-cusped aortic valve. Geometric orifice area measured by TE was 0.83 square centimeter. Usually GOA is greater than EOA in most of patients. Next. In the right ventricle function was slightly depressed and showing mild to moderate TR, and TR max was 3.1, indicating mild pulmonary hypertension. Next. In apical view, the 4-chamber, 2-chamber, 3-chamber EF was 34% without regional wall motion variety, and the stroke volume index was 21 millimeter per square meter, indicating low flow, low gradient AS. Next. In pressure profile, in 3-chamber view, aortic valve Vmax was 3.3 meter per second, mean pressure was 10 millimmercury. In right pastoral view, aortic valve Vmax 3.47 and mean pressure 12 millimmercury. Calculated EOA was 0.68 square centimeter. Thank you.
So, okay, we present a patient briefing about the low flow, low gradient, 80-year-old female, and admitted recurrent dyspnea and pulmonary edema and cardiomegaly, and echocardiography ejection fraction was 34, is quite low. So, and at this moment, we will have discussed how can you treat this patient, and any opinion from moderator and panel and for this patient?
Yeah, Do-Yoon, so maybe we can ask the panel. So, did you do any testing for this low flow, low gradient, so that make sure that it's true AS? Did you do any test, or how did you actually arrive that this is something need to be treated? That this was not cardiomyopathy.
Yeah, thank you for your question. That's a very expected question, but if this patient was mine, I definitely perform the return stress echo first. But this case was lived by our senior professor in the echo lab. He's a big guy in this field, was very informative about the severe aortic stenosis, and he said this patient did not need the return stress echo. That's the reason why we do not perform stress testing before.
Yes. Any panel and any comment?
So, anybody want to comment?
Yeah, I mean, it's a very interesting case, again, given how low that gradient is. I mean, we've all treated patients with low gradient aortic stenosis. I'm not sure I've ever treated a patient with a mean gradient of 12 for it. So I'm very glad that you're using a self-expanding supraannular valve, because at least the gradient will be lower than 12 when you put it in. But there's also a lot of MR, and it's interesting to think about how that would be managed. I assume that your plan is to see if it gets better after treating the aortic stenosis, and if not, to consider MitraClip or something of that sort.
Yeah, I mean, we wouldn't do a TAVI in this case.
Would you? I mean, we would do dobutamine and see if
at least
medical
dobutamine.
therapy only. If you can't generate 3 meters per second across your aortic valve, it's really unlikely that you have severe aortic stenosis. It's got multi-valve disease. Tricuspid velocity is greater than the aortic velocity. There's almost no calcification.
Yeah, it's, I mean, definitely, you know, it's, I mean, it definitely raises questions. I mean, I think, Vinny, were you going to say something?
Well, I think this is important. The patient has got MRT or pericardial effusion. Maybe this patient also needs a bit of optimization and then decide, which probably the team has already done. AS is today looked at as a low-hanging fruit, so easily treatable with TAVR and then see how the patient goes. But it's important to see if the mitral can also be treated, if needed in future, with transcatheter option. If not, then we are back to square one.
Would anybody treat the mitral first?
We almost never do, just because if the ventricle gets smaller, right, if the LV function improves after the TAVR, a lot of times the MR will improve. But if the LV function doesn't improve, she's going to need something to be done about that MR.
But I think one approach is this, that, you know, just treat the aortic valve, even though, because there is some calcification, they probably treated the patient with the medical therapy as much as they could, and there is nothing. So if we had to treat something, valvular heart disease, this is definitely the most likely valve that is treatable right now. And of course, mitral valve can be clipped in the future. The question is the self-expanding versus balloon expandable valve is also an important one, because developing a left bundle branch block in this patient can also create additional problem that you are going to face. So all of these things are good considerations.
Although if you are going to treat this, you do need the lowest possible gradient you can get, because you're hardly going to decrease it by a mean of 5.
I agree. So I think it's a good idea to do some kind of a stress test if you wanted to, but if clinical judgment is such that this is aortic stenosis that is causing it, it's reasonable.
I mean, the valve is thick. It's not calcified, though. That's, you know, that's...
Here it looks a little bit on the aortogram slide.
I mean, I think, you know, medical therapy in terms of the 4, you know, pillars is important here, and to making sure that you can optimize the LV, and, you know, he may need the you know, CRT in terms of getting IV. So I don't know. I think this could be one approach, but hard to know whether this is an effective approach, I would say. What do other people thinking?
But
From the IO projection, I noticed that there seems to be some coronary lesion there. If
There is no coronary disease.
lesion?
The normal coronary artery disease.
All right.
Yeah, they look pretty
Because
good.
STD change precordially, and it seems that the mid to distal or the apical wall motion is a little bit reduced. I am wondering whether myocardial ischemia is related to the low flow, low gradient AS.
Yes, coronary artery shows there is no obstructive disease. Absolutely, this is a question about what is first, the chicken or egg. So what is the, you know, ejection fraction 34 and the recurrent dyspnea. Even we prescribe the diuretics and the ACE inhibitor, and the patient recurrent dyspnea admitted with pulmonary edema and cardiomegaly. So how can you do it? Just you know, many audiences would like to hear is how can you decide the timing? Is, you know, and as you mentioned, the Martin Leung lecture, the preemptive TAVR is now could be some standard therapy. You know, this patient is ejection fraction was low, recurrent dyspnea, and admitted with pulmonary edema, and the low flow, low gradient AS. I think timing matter is the most important part is to treat such like patient.
Okay, so I think, you know, there's a lot of debate about whether this is, you know, the TAVR here is worth it, but I think technically, since you're set up, I presume you're going to do it, unless we can convince you otherwise. So go ahead. Do you also measure the dimensional index, so that, you know, do you use that to guide you about low flow, low gradient, the V1, V2 velocity?
Could you comment?
But you mean the stroke volume index or something like that?
The echocardiographic dimensionless index, you know, that we use 0.25 or so to...
less than 0.21, less than 0.25,
So
definitely.
0.21, is that what you said?
I mean, one
Colombo is
I
asking.
mean, one thing you could do here in the lab, again, you don't have all the time and you've made your choices and I don't want to change that. You could measure the gradient and give dobutamine and see what happened to the gradient here in the lab. You could do that.
So, Antonio,
If you don't have a dobutamine test, a simple way is to do a post-extrasystolic gradient.
Oh, just give some PVCs.
Yeah, give a PVC and measure the gradient after the PVC.
Well, I'm sure we'll get a PVC or two.
So we're going to show us the pressure gradient. Can you see
why
the
don't you
pressure
go ahead?
gradient?
Yeah.
Push.
Yeah.
So, and this is the incising mirror, and if you're gonna consider it's a SAVI valve, and we consider 23, and Eberhard is 26, and in this patient, is valve choice is one of a debatable matter, and we are decided to put the Eberhard in the much larger EOA. This is the frequently shown in the low flow, low gradient AS flow diagram. And the LVEDP is slightly high, and the pressure gradient is not big.
Can you give her a PVC so Dr. Colombo will be happy?
No PVC.
Yeah, but we cannot guarantee
you
some
go.
PVC.
There you go.
No, you're still not getting a PVC. She won't even give you a PVC. That's not fair.
Okay. So we proceed and the procedure, and we are using the MAC, and the last year we performed the 320 cases of TAVR, and the more than 95 cases we did the MAC, and some serious cases we do general anesthesia, and most of the cases we using monitored anesthetic care. So, and we put the wire. This is Safari and the extra small, and the territory peripheral vessel is not good. So, and 좀 풀백도 같이 보면서. Okay. Okay, 풀백. 가까이 스킵. Okay. We're gonna use inline sheath. Okay. So, and usually we are in low flow, low gradient. We usually do the dopamine stress echo, and for pressure connect.
DW, do you have the Evolute FX yet, or
Not yet.
Pro?
Not yet. Yeah.
Okay.
But we hope doing so earlier. So, and when you try to put the Evolute system, we try to in the concept overlap view.
Yeah.
Okay. Okay. First foot in the 3 o'clock. Then we're gonna push. Okay. Okay. The fresh foot and the 3 o'clock. And we already check it up the valve frame. Okay. Okay. We smoothly upper part. Okay. Yeah, smoothly. Okay. Okay, over here. Okay, and the cusp overlap view. Usually, as everyone knows, cusp overlap view in the area coral. Okay.
So, David, you have the Evolute FX. So, how's your experience been in terms of,
I mean, I think it's nice. Most of the time, you put the flush port at 3 o'clock, and it goes around, and it's pretty good. But every once in a while, we have one where we come back after reorient. So
the marker head.
the FX seems to be more stable as well. So they're not pushing and pulling type of thing.
More
So
slowly.
it's a nice incremental improvement, I think.
Release.
it's more flexible going around the arch.
Okay,
And
release. 120 pacing. Okay, release.
you
Okay,
pace it, right?
release.
Yep.
Slightly. Okay, release. Okay, release.
They're pacing. Okay.
Okay, 120 and release. 혈압 떨어지면 얘기하고 release. Okay, release. Okay, more release. Okay, more release. Testing. Okay, more release. More release. Okay, 쭉 올리세요. Release, release, release. More release. Okay. 자, 혈압 좀 보여주세요.
You have no pressure.
See, the pressure is
혈압 좀 보여줘. 오케이.
Go further.
More.
오케이. more. 우리 혈압 조금만 올려주시고. 오케이, more release. 오케이, start. 자, 오케이, going up. 혈압 조금만 올려주세요. 오케이. Stop it. Pacing off. Okay, pacing 60.
either.
Okay.
I think you're going to need to
Chiam
deploy.
To open the valve a little more, I think.
Yeah, I think should we release the valve a little bit more? I think that's one question.
Okay, more, slightly.
There's no
Okay,
pulsatility
okay,
here.
okay. I think it's okay.
Coming back
That's
up.
better.
Okay. 자, 혈압 이제 슬슬 올라가지. Okay, going up. 혈압 조금 올려주고 계시죠? Okay, going up. Okay, test.
And I think you're going to be fine. Your depth is 2.
Yeah, absolutely. Yeah.
That's good.
Go and look
Okay.
at the left side.
Okay, so another side. You know, the 김대생 올려볼게. It's a low ejection fraction and SDS score is high, and this patient showed how much, evaluation. Okay, 이제 찍어보자. 너무 세게 찍지 말고.
That's beautiful.
Okay, good, excellent.
you go
I think the
with-
pressure is going up. This is a nice position, and okay, we try to release over here. 아까 그 커스 오브레에서. 오케이, 그냥 여기서 그냥 풀면 돼. 패싱 하지 말고.
Do you release in the left view, or do you release it in the left overlap view?
Release over here.
Usually go back.
It on the left view.
Okay, tension
like to stay on the
release.
left?
Tension
Do you
release.
stay to this view?
Okay, release. Tension release.
The left.
Okay,
LAO.
tension release. Okay, tension release. Further. Upward. More.
Okay.
Okay. So, okay. Okay, another view. And we should make sure. And okay, slightly pull back. At this moment, we should check it up nose code. Okay.
It's very nice.
Yes.
Oops. Little heart block
No
there.
rhythm underneath it.
Yeah,
right?
there's not.
Complete heart block.
Okay, 여기서 하고.
Well, at least Samir, that we will buy her a IV as well.
It's like it.
Maximum cost here. So
It looks like it's hard to, deploy it much
this
more
patient's
shallow.
hemodynamics is just a one-time allowed deployment.
yeah.
Usually EF is okay, vital status is okay. We try to much, causative overlap view and the low implantation. Okay, good. And then we're gonna check it up the hemodynamics and 이거 그거죠? 자 이제 빼볼게. Okay. 자, remove. Fresh gradient 한번 재볼게요. Okay, sheath is ready. Okay. So, and one of the debatable portion is about the small annulus. And if you think about the 23 in the sapien, would you consider much bigger EOA valve like the Eberhard? So, how do you treat the small annulus patient?
Anyone?
And I think this is the SMART trial, right? This is a patient who, other than the LV function, would have been a perfect candidate for the trial comparing core valve versus sapien for small annuli. The hypothesis there is the lower gradient that's usually achieved with the core valve will translate into clinical benefit. And we'll find out soon because the patients are all enrolled in the trial. But I think a lot of us do, especially if you have a case like this where there's no coronary disease, there's no issues with covering with probably needing coronary access ever again in this patient. So I think it's a very reasonable choice.
So in Taiwan, do you still use the 20 millimeter S3 or not?
Not very often. Yeah. In small annuli, we prefer self-expanding one.
I mean, the new X4 doesn't have a 20, so it's just.
That was smart. I think that was strategic, I believe.
Fresh gradient. 여기 안 바꿔, 여기 바꿔야죠?
Well, blood pressure is certainly
Yes,
better.
we will
I
measure
presume
again
there's maybe
pressure
some-
gradient.
She may have gotten some juice, though. She may have gotten some.
It looks to
Young-Wook,
be.
is the patient on any vasoactive infusion?
Okay. Okay,
Yeah.
sorry.
We're just wondering if the blood pressure is higher. Is that from the valve or is that from some drugs that the anesthesiologist gave?
There is some drug was given. Yeah.
We have no
We cannot find an
anesthesia.
anesthesiologist.
A reader, just a reader.
Okay.
But the
Okay,
position of the valves is really high.
Yeah.
While there was
hemodynamics, I think
complete
it's
harbor.
perfect. Yeah. Can you see the hemodynamics?
Looks
Was,
great. Looks great.
Yeah, pressure gradients, no pressure gradient. LV, the pressure is a no pressure gradient, and the ratio is excellent. Yes, and so after remove the LV, pigtail, we're gonna check it up the final angio. Okay. Okay, that's the.
Goes back in sinus
So-
rhythm.
Okay, angio test. Over. 처음에. This is the okay. Cusp overlap view, initial deploy view. Okay, full shot. Good. And
Looks good.
and another view. Okay, there is no AR, and I think the depth is slightly differ than initially expected. Okay, 여기서 준비됐죠? Okay.
You're outside the valve there. I don't know if you want to be.
잠깐만요, 한번 더 집어넣고. 잠깐만. Okay, 여기서 찍죠. Shot.
Yeah.
There is sinus rhythm now.
Yeah. So I think this patient is a sinus rhythm, blood
Now
pressure is
back
okay.
to sinus.
She had sinus
Yeah. Yeah. This
good.
is true sinus
Transient.
rhythm. So, okay, the Professor Kim is how can you, post-TAVR optimal management? Could you comment on that? Such patient?
This patient has a heart rep, and we need a GDMT from now on, including ARNI or SGLT inhibitor, MRI, and beta blocker. All of the 4 pillar medication should be included in the treatment plan. Yeah.
Okay.
So this lady surprisingly has some aortic regurgitation, and given how bad her ventricle is, I think you'd either need to wait for 10 minutes and see if it goes away, and if it doesn't, post-dilate.
Yeah, I might. And again, the risk is putting her back on heart block from that, but she recovered once.
I think post-dilatation in her is critical. EF is low, and
Yeah,
the
absolutely.
other thing is not a very calcified valve.
Yeah,
So
yeah.
it's
Absolutely. AR index is
something to
quite
consider.
high. It's more
I
than
would.
40.
And your valve is not too high, so you have room if it moves.
The diastolic pressure is 87. We don't require further, inflation. I think, the final result is excellent. We have these patients a lot of discussion point. The low flow, low gradient AS. How can you clarify? How can you decide about the timing of a procedure and which stent would be better? And how can you manage post-TAVR patient? And this is a lot of some discussion point.
So in the partner study, when you develop a left bundle branch block, the recovery of LV function was poor. So, at least the left bundle branch block is not as benign as you would think, and even the outcomes for mortality is a little bit higher with left bundle branch block. So even though there is no complete heart block, the left bundle branch block you should not ignore in these patients, especially with the low ejection fraction.
Yes, and the usual care is we take care in the CCU coronary care unit. It's just 1 day, and many patients sometimes recover to narrow bundle branch and the narrow sinus rhythm, and overall status of rate of a permanent pacemaker rate is quite low, and less than 4% is quite low. The overall outcome is excellent.
So, in terms of this, are we going to do another aortogram to see how this AI whether disappeared in a few minutes? If it's there, would people post-dilate or?
So this is another question, yeah. And
Pacify David. Use a little less contrast, and then it's good.
Zero contrast.
Creatinine is okay. 65. Creatinine is okay.
It's a new grade for AR. So my important, one of the questions I forgot to ask is in these patients, 80, low EF, multivalvular disease, everything is a bit moderate. I think ruling out cardiomyopathy is very important. Amyloidosis incidence is high. And now, because we all do CT scans, what we look at is the focal ECV in these patients. And if the focal ECV is raised, it shows that most of the time the prognostic, indication and value may be less.
Okay.
I think it's pretty important in these patients to consider that as well.
Okay, we're gonna check it up, the final.
And the echocardiogram, do you do the echocardiogram at the time? Because I think it is a transthoracic echo will be helpful to know
yes,
that
transthoracic echo. Could you, yes, Professor Kim, could you show again?
And the dicrotic notch, if it comes
Okay, got it. We're gonna show
below the half,
immediately.
there is some.
Okay, good.
Wow. Ejection fraction seems to be improved.
Ejection fraction improve?
Yeah.
That's a good sign. We've got a lot of MR.
There is some PV leak.
Yeah.
Some PVL there.
Some leak from the valve.
I think it is a little bit more than you need, so probably post-dilation is not a bad idea for this
Maybe
kind
a
of.
22 balloon.
Sorry, did you see a fair amount of AI or?
Yeah, you can see it.
I missed
There it is.
Sorry, yeah.
AR index more than 45?
Yeah, see that little, all those little pixels.
But to our experience, if you post-die, you will just impinge the metal in the septum. So that will cause conduction disturbance.
The truth is she probably needs, she may well need a biventricular pacemaker anyways, which is the best thing probably for her.
Yeah.
An ICD too, right? Because
I'm just spending a lot of money.
From optimal medical therapy to become TAVR,
just mild.
IV,
Just mild.
ICD.
From the 12 o'clock.
12 o'clock, just
Yeah.
mild. Okay.
I was thinking at the start of dapagliflozin and a cup of tea. And now she's...
You need your 4 pillars of heart failure first.
Yes.
He's got pulmonic.
Okay,
reviews
we
too.
will check it up the final aortogram and then move to another case. Okay.
Okay.
Okay, ready? Okay, test. Yes. Okay. Okay, possible test.
In the LAO view, you want to do it or this way?
LAO view. Okay, go. Okay. Ready? 준비됐어? Okay, enjoy. Okay, yes, it's just a mild PVL. Yeah, I think much disappear. Okay, I think the overall result was excellent. Hemodynamics is good, and the echocardio specialist comment EF already slightly improved, and overall the procedure was success and no complication. I think this is a very nice demonstration, debatable remaining unmet need part in the TAVR interventional field. Okay, Alan, and
Right.
could you?
Yeah. Thank you. I know that this is a tough case in terms of decision, what to do, and I think, certainly don't want to harm the patient, but I think, there are more works to be done for this patient, unfortunately. So thank you very much, Jung-Woo.
Thank you,
So should
DW.
we-
Okay,
should we-
thank
any
you.
more questions?
Thank you. 수고하셨어요. 네.
Let's go to Jung-Min. Jung-Min, we are all here with you. And
Can you hear
Dr.
me?
Khan, yeah.
Yeah. Can you hear me? So good afternoon. Good afternoon. We are prepared. We are ready for the second live demonstration of TAVR case. We also very similar cases. So we need many discussion with the audience and chairman, with the echocardiographic specialist, Professor Kim. So Dr. Kang, could you briefly introduce patient history?
The patient is a 74-year-old female with hypertension and admitted for dyspnea. She has a dyspnea of the New Heart Association grade 3, and she has a history of previous cardiac surgery, mitral valve replacement, tricuspid annuloplasty, and major operation with the ASD closure 20 years ago. And she underwent permanent pacemaker implantation 6 years ago. Next. And her echo showed severe aortic stenosis, and because her previous valve surgery, the cause was the rheumatic MR. So the patient, it was rheumatic MS, sorry. So, or I think that she also has the rheumatic AS. And the STS score was 5.8%. And next, and the patient, the EKG shows the pacemaker gated rhythm. And next, and the chest X-ray shows borderline high cardiomegaly. Next, and we checked the echo, and LV ejection fraction was 31%, and the Vmax was about 3.3. And we performed the dopamine stress echo for this patient, and the transaortic valve after dopamine stress echo was of 4.2 liter per second. And so we diagnosed the real severe aortic stenosis with a low flow, low gradient. She also has the RV dysfunction and moderate TR. However, the mitral valve function was okay. So she underwent a rigorous volume reduction with the IV dopamine and diuretics, but still she had severe dyspnea and could not be discharged. So we decided to perform the aortic stenosis treatment. Next. This is the CT finding of the patient, the contrast CT. As you can see that the calcium amount is low. This is the first point. And the annulus short diameter is 19 and long diameter is 25. Annulus area is about 400 square millimeter. Next. And the aortic valve, the sinus valsalva and ST junction size is okay. Next. And LVOT, there is no severe calcification. Next. And this is the total calcium amount. We can see in the CT and angio also that calcium amount is low. Next. And the annulus to mitral prosthetic valve length is 4.5 millimeter. Next. And the aortic stenosis is okay. The aortic aorta is okay. Next. And corneal height is about 12 millimeter from the annulus. I think it's quite high enough. Next. And next. And we plan to treat the patient with the SAPIEN, and in this patient, 23 millimeter plus 1 cc, that makes about 12% oversizing would be good with that.
Okay, thank you, Professor Kang. So we also have, here is also Professor Kim, the echo specialist. Could you discuss the echo finding of this patient? Similarly, the very low ejection fraction, similar to the previous patient, very low ejection fraction, and the resting Vmax is less than 4, but this patient did the dopamine stress echo. So could you explain?
Dopamine stress echo.
Yeah.
The next slide, please. This is an echo from this patient. The LV function severely depressed, and every chamber was slightly dilated. The endoscopic dimension was 49 millimeter. Can you clearly see moderate degree of AR, and the mechanical mitral valve was replaced? Next slide. And short XQ, the etiology of aortic stenosis seems to be rheumatic pathology, tricuspid, and planimetry measured by transverse surgery echo 0.83 square centimeter. Next. In RV focused view, the RV function was slightly decreased, and tricuspid annuloplasty was performed, and the mild to moderate TR was seen, but TR Vmax was 2.9, indicating no evidence of coronary tension after we performed the aggressive diuretic treatment. Next. In apical view, the LV function was 31%, ejection fraction 31% without regional wall motion overactive. The stroke volume index was 22 milliliter per square meter. The mechanical mitral valve function was good, measured by mitral mean pressure of 2.5 millimeter, and MV area measured by pressure times 33.1 square centimeter. Next. We performed the stress echo in this patient, but because this patient was mine. At the baseline stage, 3 microgram dobutamine was infusion at max peak mass was 3.6 ml per second. Mean pressure was 27 millimercury. The ejection was 32. EOA was 3.7. At the stage of 5 microgram, the aortic valve thrombin was 3.7 meters per second. Mean pressure down to 29 millimeter mercury. EF was 35%. EOA was 3.8. At the stage of 7.5 microgram, the aortic valve Vmax increased up to 4.2 meters per second. Mean pressure on the 38 millimeter per second. EF was 39 and EOA was 0.7. We wanted to go further. The patient was interned to the ductal infusion. As you can see, the beam pressure was 38 millimercury. We have over 40 millimeter mercury in ductal space of Bapat. But the confirmation of SAVI-AoS that there is no problem. There is increase in ejection fraction, stroke volume increased greater than 20%. The EOA still remain around 0.7, indicating true severe stenosis. Thank you.
Thank you, Professor Kim. So we summarized the whole patient history and echo findings. Do you have any comment or question on patient history and TAVR indication, etc., etc.?
So, Jung-Min, so this patient has had surgery before. Is that sort of a serial echo over the years in terms of whether the aortic stenosis got worse or the ventricular function got worse? Is there a past history of those numbers?
Yeah, actually, Professor Kim.
That's right. Progressively decreasing ejection fraction and progressively increasing in aortic stenosis. Clearly.
So another interesting point is this patient AS pathology would be the rheumatic, not degenerative. So is it right?
Yeah, I think that not definitely rheumatic, but in personal long acute period, it seems like rheumatic pathology.
Yes.
Okay. So people would just go ahead and proceed with the TAVR here because obviously with the tobutamine much more helpful.
Yeah, and I think in this particular patient, with a rheumatic heart disease, calcium score is not so important. So I personally think that this is a very significant AS. Whether you want to upgrade the BIV now or you want to do it after you do the TAVR, I prefer the after TAVR because maybe the EF improves and you do not need the BIV pacing. This would be the only consideration. Whether you put a self-expanding valve or a balloon expandable valve is also a good question. But I think she's 74, and if she needs another surgery, explantation is easier with the balloon expandable valve. The size is good with this, so balloon.
Worry about a balloon expandable with the mechanical prosthesis?
Yeah, I mean,
I don't.
Yeah, I mean, that's, I think, a procedural consideration. I think in CT now, like here, you can see a good aortomitral curtain distance, so shouldn't be a problem, but something to make sure that when the balloon goes up, it's stable when you are deploying it, and when they are really close, and in older types of mechanical valves, a low deployment can interfere with leaflet closing.
So would you, in that case, favor a retrievable valve, a self-expanding? If it was very close, not like this.
Right. But I think only if the aortomitral curtain is very near. It's interestingly, balloon expandable anchors better. If you use self-expandable and it's a very narrow margin for landing, you have to be experienced enough to do it. So again, to keep in mind that in such situation, better to use the valve you're good at rather than this versus that.
So Vini, in mechanical valve, I think Jude, when you put in mitral position, do you orient in a certain way so that the bileaflet is opening in a certain direction?
Yep. So one can orient in a way from septum to the LA appendage, so to speak. But some of these valves can self-rotate inside later, depending upon the flow. Not so much in mitral because it's low flow, but in aortic for sure. But we have never been orienting it in a way with future considerations. So that's something we should definitely think about as well.
I think when you look at this picture here, you think they're very close. The lesson that I've learned in my active time is just try to ignore the mitral valve and position the aortic valve the way you usually do.
I agree, yes. Very rarely with the bioprosthetic valve, if they're not oriented right, you can rupture the balloon.
Yeah.
But this is not very common. So I think I agree that just ignore the mitral valve and put it right.
Where you normally would get a couple millimeters depth.
So Anjun, Jin-Ming, just go ahead and
Thank you for very important comments. So we are prepared the transfemoral approach. We'd like to implant the volume expandable valve for SAPIEN 3 Ultra. So yes, I think this patient pathology would be the rheumatic, dominantly rheumatic plus the degenerative component. So this is a wire.
Whilst you're crossing the valve, well, that didn't take very long.
Okay.
I was just going to ask,
Normally, in this situation, if you have a pacemaker, you can use the pacemaker. You don't have to put another one. You can just use the pacemaker that you have and pace from there.
We always had trouble figuring out, you can't ramp up as quickly, right? With the,
No, you can.
Can you?
Yeah. We published a paper just to put all the different pacemakers pictures to say how you can do it. So it's in CCI. So you can just look at all the pictures, Medtronic, Abbott, Boston, how to do it.
Because we tried it a few times in Kansas City and had trouble ramping it up fast.
I think what's interesting is if patient has micra, and we are going to see more patients with micra. So with micra, you can put a magnet on the abdomen. We have done that tricuspid TMVR recently. The only thing is you cannot alter the rate. So you set the rate, say 180. You can't step down to 120. You have to cut it off and reset it again. So that's the only issue, I think. Yeah.
So, Jin-Ming, did you use emerald wire? What wire did you use to cross?
Oh, Teflon straight wire.
Teflon straight. And did you have uninterrupted warfarin, or have you used some other ratio?
We didn't uninterrupted warfarin because we need the anticoagulation. So I'd like to measure the pressure.
Heparin bridging during before the procedure we did.
That's a good question because there are several trials now showing that uninterrupted anticoagulation is probably better than trying to stop and restart. So,
I agree.
Yeah.
Just putting a big, a 14 French sheath in with INR of 2.5 is not fun. Or not,
But make it 2-ish and then do it. That's the.
Just drop it a little bit, I think, generally. But obviously, it depends on the indication.
Actually, consistent with the echo findings, the resting pressure gradient is not that big. So we already confirmed the severe AS based on the stress echocardiography. The peak velocity increased more than 4.0. Actually, there is no doubt on the indication of the TAVR procedure. So after pressure measuring, I like to insert the Sapari wire with a small coil. So it's very interesting that both patients, the first live demonstration patient, this patient, the aortic valve calcification is very, very low. Recently, we analyzed our data based on the aortic valve calcification. Actually, we cannot explain it perfectly, but the low aortic valve calcification, the procedural outcome is similar to the high aortic valve calcification, but the long-term mortality is unexpectedly higher in patients with low aortic valve calcification. So this finding is suggesting that the AS may be associated with predominantly, some patients predominantly calcific process, but some patients dominantly non-calcific fibrotic process would be the major cause of progression of severe AS.
Is anybody on the panel routinely pacing on the LV wire these days?
LV wire?
You are?
Yeah.
David?
Yeah.
And your experience?
Yeah, very good. Well, pacing on the LV wire?
Yeah.
I mean, we've done it for, I don't know,
It's not
years or something.
I mean, Alan, are you doing it?
No, we have testing this wire that has the SAVI wires, the SAVI wires. It's okay.
SAVI wire, the one with the pressure measurement?
Yeah, the problem is it seems like it coated with material that is really sticky. So it won't be able to come out of the pigtail.
Oh.
And a couple cases that we're testing it just won't come out. Even changing the French pigtail, it won't come out. Maybe it just tolerance issue, who knows. Well, the other thing is, if you have to choose transducer, I think that's worth something. But otherwise, you have to use a pigtail again, and it's cost $800.
Exactly. So this is what if you are going to pace on the wire, you cannot pace on the implant extra stiff very reliably.
No, you can.
You can. So this is why the expense of the wire is unnecessary. So that's why we don't use it.
Yeah.
Yeah, the Amplat Super Stiff works fine, the Safari works fine. You just have to have a box that goes to 15 volts.
Mm-hmm. Actually, very low aortic valve calcification. We don't need the pre-dilatation, and the valve easily passes through the stenotic aortic valve. So test it, please. Okay.
I think you're very low.
Test it.
Yeah, you're low. Yeah, I think. Yeah.
이거 맞나? 한번 찍자. Ready? Okay.
That looks good.
I think it's a good position.
Yeah.
Ready? Facing on.
Facing on.
Contrast. Okay, inflation. 4, 1, 2, 3, 4, 5. Deflation. Facing off.
Facing off.
I think
Patient vitals.
this qualifies as slow inflation in Asan Medical.
For Asan Medical Center, this is slow speed. you didn't do it within 1 second.
And what about?
We have routinely used the cusp overlap method for this valve also, because it does exactly the same thing as you saw in the previous example, that you can implant it higher rather than.
I think it's nice to use. And again, we all trained using the cusp view, but the cusp overlap is so nice.
Similar.
Look at, unfortunately, you can see that there is some distance between the low margin of aortic valve and then mitral valve. So the mitral valve movement is very nice. Yeah, totally the group, Dr. Grube is correct. We just ignore the mitral valve and focus on the aortic valve implantation.
Just like Mac, it is there, but it's not really related to each other, type of thing.
No, you just, you don't want to interact with it. But I think Eberhard's, approach of ignore it as best you can.
Definitely don't want to wire an LV to curl up and go into the mechanical valve.
Commissures are well aligned just by chance, but usually when you mount the Sapien, if you put the commissure at 6 o'clock, there is a 80-90% chance that if you don't turn it, that you will align it just like that. So this is a good commissural alignment.
So Samir, you're basically seeing the valve, and there's this double little thing here. It's the commissure.
Yeah.
And basically like the X4 that is behind, the 3-cusp view is right behind, and that's where the commissure is, right?
So if both of them are on the left side, means near the left side, then it's very likely to be aligned. And in the RAO view, both are in the back rather than the front, then they're aligned.
So it's the same as FX has got markers now.
See,
You can
like this.
use the same.
Here we have the little square, the little rectangle.
So after the echo evaluation, we will discuss further. Could you, Professor Kim, could you evaluate the echo?
I think the other important thing is now with CT scan, you can pre-plan and understand the distance for landing better than in the old days where we used to guess on fluoro. So orientation of bioprosthetic valve, if in mitral was there could be some challenges, but this looks quite good.
Yeah, there is no AR, so it looks good.
Is that a tiny bit? Tiny bit?
This is the artifact.
Or is there a wire still on?
Wire, I think.
Yeah.
Yeah, the wire you stay here maybe. Dr. An, maybe trivial parabolic and then the many catheter induced here. Okay. Yeah. Thank you.
You want to pull the wire back and see if it goes away? Make sure.
Very tiny. Right?
Wires in the LV. Yeah.
A wire is in the LV, so if echo show that no severe significant AR, so I like to change the wire to the pigtail.
Yeah, mainly category scale.
Yeah, thank you. Thank you, Professor Kim. So I like to change the supply wire to the pigtail to measure the pressure gradient between.
Now you're out.
Sorry.
That's okay.
And then, okay, it's
We will
okay.
leave you.
Okay. Anyway, let's check the aortogram and let's see the valve performance. Ready?
Ready.
Actually, no regurgitation.
That's good.
Yes,
Nice.
can you see there is no regurgitation. Yeah, we can see the thickened aortic valve outside of the stent. Yeah. This is a kind of the rheumatic pathology, I think. Thickened aortic valve. Yeah. So patient already have the pacemaker, so we don't consider the patient rhythm, and then there is no residual the paravalvular leakage. There is no interruption of the mechanical mitral valve movement. So I'd like to start my procedure now. I will close, retrieve the whole device, and I will close the femoral approach site.
I mean, this, for TAVR, for this type of patient, it's just so nice, right? You have previous surgery already, you have, tricuspid surgery, and you have mitral. Otherwise, you have to open up the chest again.
Yeah.
I mean, this is such a nice thing for patients to have, especially if they have moderate or mild AS before, and they don't want to change the valve at that point. So I think it's a great advance for this type of patient to have really much less invasive type of therapy. So, any comments for Jung-Min?
Actually,
beautifully
I
done.
didn't have more.
No, I think outstanding. I know that they used two different groins. I routinely use single groin access, which is something to consider if you guys like.
You stick twice?
Just stick twice.
And pigtail through radial or?
No, pigtail in the lower one. So just stick the femoral artery above, femoral artery below, put the pigtail from below. So at the end, you take out the big sheath and then take a picture from the same side, so you don't have to cross over.
But your vessel has to be adequate size. Right?
No, good size. Everybody works. So if we can put TAVR valve, we can put a little pigtail.
Yeah, I wouldn't do that.
5 French, 6 French, doesn't matter.
I wouldn't do that. The superficial femoral with uninterrupted warfarin.
No warfarin, maybe not, but again, not. That's one, and the second is of course, the question will come up, the emboli protection devices, whether you use it or not. Both of the cases we didn't, but this is a question. Again, no conclusive data, but there's something to consider.
But Alan, you made a great comment. This is a patient with not just re-op, but moderate LV as well. With echo, it looked worse than the number. This is definitely a high-risk surgical candidate. He's had a tricuspid repair as well before. So TAVR actually is the best thing for this patient. And she's on warfarin, so you won't see halt, I think, which you normally see in 30% of TAVRs. Is that right?
Yeah, so I think this is again, I think the main questions here are these sort of very tiny little procedural nuances that people do differently, like the pacing on the wire, which again is getting some. I think in Europe it has more traction than the U.S. right now, for whatever reason, for it, and embolic protection, obviously, and then sort of how do you handle this mechanical valve, which I think was done very nicely.
Is it the electric current, 110 and 220 volts? Is that the main difference, David?
That's the, we just need a.
Because in US, for some reason, there's a hesitancy in using, safari wire while in Europe, everybody does it.
Safari is much more expensive than
And Amplat's extra stiff. Go ahead, David.
No, but I think the issue is that if people are using it for the S3, then you have to generate that confidence and reliability in your mind before you're willing to do it. So we did hundreds of cases with self-expanding valves first. And once we were really, really happy with it, and we thought, okay, we can justify using it for the S3 as well.
But you're perfectly, you don't, with balloon expandable, you don't worry.
No.
Why do you use David?
We use we use an extra stiff for balloon expandable, and we usually use a double curve Lundquist for.
If it's a problem, right? Samir, why do you use?
So we use extra stiff, Amplat's extra stiff for the balloon expandable, and for the Confida, typically for the self-expanding valve.
So Professor Kim, the echo specialist, mentioned that the ejection fraction is also slightly increased after the valve implantation. So what a TAVR.
Yeah, that's good. That's good to know, and that's good for the patient.
Yeah, I think there's great two cases of low flow, low gradient. Obviously, somewhat controversial in the first case, but this one is, obviously sort of more what we all do, like butamine, trying to figure out whether it is real. But still a tricky population, I feel like. Even this is documented that way, but do the EF actually improve?
Right. These patients.
Can you see the echo?
The main thing is these patients weren't in the trials, right? These were not in the randomized trials because you couldn't give dobutamine.
Yeah.
We treat them all the time, though. This way, they won't do as well as a patient with normal flow, normal gradient, but they'll do a hell of a lot better if you don't treat the valve.
I think just like what Marty talked about, there's something happened to the ventricle, whatever that is. Whether it's some people who have obviously coronary disease, and some people have rheumatic disease that have myocardial damage from before, or long-standing valve. There's a lot of grab-back patients that have this problem, and you can't really sort of say, well, they're all the same. So, and sometimes the valve is really calcified, and you can see, but sometimes it's like there's nothing, and you don't know what to do.
Yeah, no, the worst ones are the paradoxical low flow, low gradients. I think these ones, you can at least give dobutamine and convince yourself the gradient is increased, and maybe the LV function is increased, and there's going to be some myocardial recovery. In the paradoxical ones, they're just, they have some other condition that's not going to be corrected by treating the aortic valve that is making them have low flow, and that's going to persist. But again, still the prognosis is better with correction than not. So I think, we've sort of trained ourselves to, really rely a lot on the echo. If we're really on the fence, we use the calcium score to help differentiate with, margins of 2,100 for men and 1,200 for women. That's another factor that we use in the paradoxical ones.
So, Dr. An, I have a question for you. You have some data from Asan Medical about low calcium score NAS and how they compare with high calcium score NAS. Any new insights?
Yes, we just submission and revised the manuscript. The overall population, we defined the low aortic valve calcification for women less than 1,200 or men is less than 2,000. So consists of the 25% of overall TAVR and SAVR population. We included the SAVR and TAVR both. So we found that long-term mortality is significantly higher in patients with the low aortic valve calcification. So actually, not easy to explain these findings, but based on the other report that low flow, low gradient is associated. Yes, we only include in this study only significant Vmax or pressure Vmax is more than 4. But the other studies show that the low flow, low gradient is associated with the low aortic valve calcification. In addition, low ejection fraction is also associated with the low aortic valve calcification or with the severe AAS. In addition, some patient, some case report to publish that amyloidosis patient, the aortic valve calcium score is low compared with the the normal calcified AS population. So in addition to another important thing is ESRD end-stage renal disease patient unexpectedly they have the low aortic valve calcification. So some proportion of patients who have a severe aortic valve stenosis, the fibrosis, non-calcified process is more important than calcification itself in the progression of the aortic valve stenosis. Great. But the exact underlying mechanism, how important, and what is the cause of the higher mortality, we need more data and we need more studies.
I mean, that's a very interesting finding that's surprising, I think.
Yeah,
to hear that. You would think that it would be the other way if I was going to guess anything from it. It'll be very, you said is the paper is in press, did you say, Jung-Min? Or coming soon?
Yes, we're coming soon. So we are under the second revision, so I think we're coming soon in this year.
Very interesting. Yeah. One fun fact is that, if you have a low gradient AS, if you measure the peak of aortic and peak of LV, obviously like how you measure the delay of the pulse in the cath lab, and if it's more than 40 milliseconds difference between the two, then it seems to be a real AS. So this is what we published in JAMA Cardiology. We measured all of those and correlated it with the calcium score and with the outcomes and all that. So this is a simple, difficult to do with the echocardiogram because there's no way to measure the peaks and peaks. But if you're in the cath lab and if you see the peaks are 40 milliseconds different,
but you have to do it with transducers, literally catheters on immediately on either side of the valve.
Either side of the valve. So like two catheters, like how you do just before the TAVR. This is what we did before the TAVR. So just for fun,
That's an interesting correlation.
Yeah.
But you have to be sure that the fluid system is.
Yeah, everything.
You don't want to have delay.
You look before you put them across.
And I think.
Do a real hemodynamic study.
Correct. Yeah. All right, Jung-Min, I know that you're kind of bored, standing there, right?
He's holding the groin.
No, he's holding the groin. He's on warfarin.
No. While we are talking, the bleeding stopped. So we finished every procedure already.
Thank you very much.
Thank you very much. Great team. Thank you.
Thank you.
After those two interesting live cases, now we go to the lecture part. Alan will be talking about the upstream management of aortic stenosis.
Thank you, Eberhard. For those of you who were here this morning on the keynote lectures in the opening, I think Marty has really addressed some of this issue already. So I'll try to sort of put a bit of my own thinking into this talk and hopefully remind you some of the concepts. So when I saw the title, and I know this title has been sort of around, meaning looking at this upstream management of aortic stenosis, I don't really sometimes know what it means, meaning that there's a lot of upstream from aortic stenosis. So when is it actually upstream? But I think we all are very comfortable and understand the upstream management of coronary artery disease, meaning that we know the pathophysiology, and by knowing the pathophysiology, we therefore know what the risk factors are and what risk factor modification means. For example, obviously lipid lowering, smoking, cessation. And also we kind of learned and what can we detect? Are we looking for calcium score? We obviously have CCTA, stress testing, invasive angio. And then we can also develop criteria for treatment, symptoms, anatomy, FFR, for example. And then you have treatment options. And then finally, you can measure the effectiveness and durability of treatment options. So if we use this concept to look at what upstream management of aortic stenosis, let's look at the first two, pathophysiology and risk factors. And I would say that we don't really know very much. So if you look at the incidence of aortic stenosis, generally, I think as you sort of look at most data, by age 75, the numbers is hovering around 4 to 6% in the population. So clearly it's not everybody. So it's not like the aortic valve wears down by 75 and at 85 they're going to close. So clearly it's still a subpopulation of our sort of octogenarian that develop aortic stenosis. But that number may be a little low, meaning in the sense that we're talking about an elderly population. So when you look at a curve like this, by age 80, seems like things to kind of start to fall in terms of the numbers. And that obviously is due to multiple factors. And clearly because of the life expectancy, people will be dying from other disease state while the valve maybe start to narrow. So it's really difficult to know sometimes what exactly aortic valve are doing in the elderly population. So, but clearly one concept is that not everybody is going to get aortic stenosis. So therefore, we have to understand the pathophysiology behind this. This has been sort of just to remind you that the concept is that there is endothelial injury, just like any vessel, any surface that's exposed to blood. But there is also something to remind you that the valve that we have actually has cells in it. It's just not collagen and fibrous tissue. And these cells are actually very much similar to the smooth muscle cell that is in the vascular trees. So these can be activated due to a variety of inflammatory stimulators, and then once they have been activated, they create a variety of things in terms of the extracellular matrix deposition, and tendency is actually create osteoblasts. So therefore, calcification, microcalcification, become macrocalcification is one of the response of these cells, and therefore obviously participate in start to stiffening and eventually calcium deposition on these valves. The other part, obviously, is the concept of what is the heart itself, the LV, is doing as this valve is stiffening and not able to open. Obviously, you have hypertrophy, you can have diffuse institutional fibrosis, and subsequently may have some replacement fibrosis. But we know that these risk factors seems to be related to aortic stenosis development, seems to be, at least the first pass, also very similar to atherosclerosis. So at least there's some overlap with atherosclerosis, but at the same time, a lot of the people who have atherosclerosis do not have aortic stenosis. So there's some divergence in terms of the pathophysiology. So one of the obviously early sort of observation, if indeed this is kind of atherosclerotic-like, can you lower the cholesterol? For example, the sort of early, a couple of decades ago, looking at some of the sort of single arm, looking at 180 participants and lower their cholesterol by treating with a statin, seem to have shown some, slowing down of the progression. But clearly, in bigger study, for example, in looking at smaller numbers, but looking at the aortic velocity, clearly over 36 months, no change. But one point to point out is that these patients generally has a fair amount of aortic stenosis already. So it's not like these folks have very mild aortic stenosis and you're trying to prevent the narrowing of these valves. A bigger study sees in 2008, again, showing the incremental change is very little difference between the treatment group and the placebo group. And finally, similarly, numbers are still relatively small, but so far looks like the statin doesn't make a whole lot of sense to use to treat aortic stenosis. So therefore, really today, there's really no medical therapy for it. I mean, there's postulation of various things, but nothing has shown to be really affecting the pathophysiology. I think my own interpretation is that we really don't understand the pathophysiology that well. So the part that is probably more interesting is really this particular paper that go back a long time ago is really looking at sort of the genome-wide association study, the GWAS type of study, is really looking at a bunch of genes and see which one actually somehow associate with aortic valve calcification. And Lp(a) is actually turns out to be a pretty correlative, but these again, there's many genes, and this little dot on the top is really the genes that produce abnormally high Lp(a). So again, this makes a little sense because the number of patients who have elevated Lp(a) is about 20%. So therefore, if you sort of say, well, some subset of this patient population could end up with aortic stenosis, that could be some part of that pathophysiology. So obviously, the modern thinking is that aortic stenosis is sort of like atherosclerosis, but clearly not just atherosclerosis. And there's also maybe potentially there's an osteoblastic disease component, meaning these sort of valve interstitial cells are somehow abnormal genetically, and therefore they create abnormal response to the stimulus, hemodynamic stimulus, and create extra microcalcification, for example. So obviously, potentially, these are all a pathway that can be intervened on to slow down this process or stop this process. So obviously, I think there's a bunch of studies going on looking at the most exciting one, probably the LP(a) trial, as we have better treatment for that, and not obviously using niacin per se, and it's really to see whether that indeed could be a process that can be stopped. But I still think that majority problem upstream is really we don't understand what is the pathophysiology of aortic stenosis. And clearly there are octogenarian that we see and carry and follow through that have pristine aortic valves. So it's not really something that has to be automatic over time. And I think the risk factor modification, the trials that we're talking about, are patients who have had significant aortic stenosis already. So one question I have is, are we intervening early enough? If we talk about somebody that has some aortic valve calcification, maybe that's the time to intervene and not wait till they have sort of a gradient across the aortic valve. So I think that's really the question, should we study aortic stenosis progression, or we should be studying aortic stenosis prevention? The other part that I think is we all know that when you have bicuspid aortic valve, the valve becomes a problem much younger. Typically in the adult population is in the 60s. But at the same time, we see many valves that have sort of a slightly fused commissure. So I think the question is that are all tricuspid valves born equal? Meaning if your three leaflets are slightly off, they are not 120 degrees and they are made only at 110 and one is a little bigger, or there's some fusion, does this set up hemodynamically for those valves to degenerate? So I think that's a very interesting study, but it's difficult because we don't obviously do echo on everyone or do CT better in everyone. Again, we talk about the LV reserve and response to aortic stenosis. There might be variants, again, who actually could create a much higher a gradient without symptoms, for example. So detection, I think, Marty talked about this a little bit. Nowadays, whenever we give a talk, we have to say artificial intelligence, because if we don't say that, it seems like we are not really, sort of in the forefront. So I would say that it's AI, machine learning, the keywords. But nevertheless, can you detect aortic stenosis much earlier? And I think there's some potential, but I still think that's pretty early to say. I think the other thing is that whether it's sort of a calcium score equivalent for early aortic stenosis, meaning that when we do CAG for coronaries, should we be looking at the valve calcium? And meaning any calcium should be abnormal. So therefore, should we be looking at, rather than the severe aortic stenosis calcium score, is really the zero aortic valve calcium score. Given the time, I'm just going to jump really quickly, just really going to talk about that, the aortic valve, when they start to narrow, there's a lot of things going on, and not just until you have symptoms, everything is good. And again, the symptoms sometimes could be very difficult, especially in the elderly. Sometimes they have no symptoms, sometimes the symptoms are so vague. So this has been shown already earlier today. I'm not going to go through this too much, meaning that nowadays we're really looking at staging of the severe aortic stenosis in the ventricle side, and see how they do, and knowing that the ventricle that are really in bad shape do much worse. And also this is true in also moderate aortic stenosis. So this is really a continuum. As you sort of develop a valve problem, you also could develop a ventricular problem. And again, this sort of classification helps you determine whether patients with moderate aortic stenosis, what is their 5-year mortality. So clearly now we understand when we want to study aortic stenosis, we want to understand aortic stenosis as well as the LV response. The surgical literature shown that if you are asymptomatic but have significant aortic stenosis, it would actually better to replace the valve, and they have much less adverse event over time. So these are trials that obviously looking at preemptive treatment, and early TAVR has been finished and going to go into follow-up. And also patients who have actually risk factors, meaning that they have moderate aortic stenosis, but a lot of things going on in the ventricle that potentially could be a problem. Therefore, fixing aortic stenosis early could be beneficial to the ventricle. So to conclude, really, I think going forward, we also need to look backwards, is that we need to look at the valve, how we grade the valve. We also need to look at how we grade the ventricle. AVR, whether it is TAVR or SAVR, is really a very small number of this sort of population. And obviously, we try to understand moderate aortic stenosis. What does it mean? Should we treat them early? And finally, what is the drug treatment for these patient population? And I think the answer still now is unknown. So to me, upstream sort of management of aortic stenosis is really, first step is understand better what causes aortic stenosis and going forward there. Thank you.
Thank you very much, Alan. And we move on to Dr. Johnson. Moderate aortic stenosis physiology, the ongoing SAVI versus AoS trial.
Right. Thank you. Hello, everybody. So I want to start off with two big picture concepts. The first is that it's a little weird the way that we grade valve disease, right? Because patients have symptoms, and that's when their hemodynamics are causing the problem, but yet when we measure them when they're sleeping on the echo table or sedated in the cath lab, that's when the patients aren't having problems. And so if we're trying to understand what are the hemodynamics that are producing the issue, we're measuring it at exactly the wrong time. And so that's a bit of an internal contradiction. The second is what we'd really like to have is an index that tells us about how much the stenotic valve is limiting peak flow, a fractional flow, if you will, right? So we'd like a parameter that tracks the reduction in peak flow, not resting flow, because most of our patients are in shock, but in peak flow as the valve becomes stenotic. And so with that background, I want to talk a little bit about the way that we should think about the physiologic fingerprint for a stenosis. And that's the relationship between the pressure loss across the stenosis and the flow. And there's two general patterns. One is where it's a straight line, and so these behave like resistors, right? So this is all due to viscous or friction losses. The other end of the spectrum is a pure orifice, right? And these have a quadratic pressure loss flow relationship due to exit or separation losses. And back in 1951, as you can see here, the good Dr. Gorland and his father put forward the theory that stenotic valves behave like an orifice, and so we should expect them to have this quadratic pressure loss flow relationship. In other words, the aortic valve area then would be a reasonable way of describing the physiology of the valve. And it turns out, when we've made these measurements now about 5 years ago, that that's simply not how severely stenotic aortic valves behave. In fact, if you look at the pressure loss versus flow characteristics of them, the vast majority behave in a way that's not even as bad as a resistor. That is, if you double flow across a severely stenotic valve, you don't even double the pressure gradient. In fact, most of the time, the increase in pressure gradient is much more modest. Very few valves behave as a fixed orifice. And so the reason that that happens is changing valve geometry, in my belief. And this is some work that we're doing at the moment where we're taking some of the CT scans and running computational fluid dynamics and then increasing the valve flow through augmentation of cardiac output. And you can see here in this particular example of a patient who has a calcific aortic valve, as that increases, the valve geometry increases, and that's why it does not behave like a fixed orifice. Now, at the other end of the spectrum, it turns out we're also wrong in terms of thinking about aortic valve or effective orifice area. So we made several measurements in patients who had TAVIs, and as you can see, pressure loss flow relationships there are extremely linear. In other words, when we talk about a TAVI prosthesis, we should really be talking about its resistance. And the same, I think, holds true for normal valves. On the right-hand side is some work I'm doing in an animal model where, again, you see a very highly linear pressure loss flow relationship. In other words, valves, for most of us here in the room, simply behave as resistors. And that brings us to the notion of what we've called the stress aortic valve index, or SAVI, which is a way of thinking about it is that this is an FFR for the aortic valve. And in terms of practical ways of measuring it in the cath lab, it's very much a procedure like FFR. The wire is equalized, cross the valve, bring the guide in, put in the pressure wire into the ventricle, and then pull the guide back. And of course, that's how you make the resting measurements. But the key piece then is to turn on dobutamine for a period of time in order to increase flow across the valve and understand how it looks under peak stress conditions. So let me just walk you through the types of data that would come out of something like a typical case. This is about a 9-minute or so infusion of dobutamine. We use fixed-dose dobutamine. That's actually a much better pharmacodynamic match for the way dobutamine works. And as a result, the heart rate increases, right? So it starts off around 60 and goes up to something like 100. Now, every single dot on here is an individual cardiac cycle, and what I'm showing you in blue for every single heartbeat is the average pressure in the left ventricle during systolic ejection, and then the line behind it is a trend line. And I've added here then the same data for what's happening in the aorta, and of course the difference between those two is the mean transvalvular pressure gradient for that cardiac cycle during the course of dobutamine infusion. And so, not too surprisingly then, the gradient goes up as you drive extra flow across the valve with dobutamine. And the key piece then is to take the ratio of those two, that's the line in black, looks very much like, if you will, an FFR curve as you're giving adenosine, right? And the lowest value there on the right-hand side is a value of 0.66, and that's the SAVI. What it means is that this valve is limiting flow, peak flow, across the valve down to about 2/3 of normal. And that then comes back to this issue of what do we really want to have an index that helps us measure? And I would put forward that what we want to understand is how much our stenotic valves limit peak flow. Because again, when you're just sitting there at rest, most of you wouldn't be, and most of our patients are not in cardiogenic shock. So it's an issue of limiting maximum flow. And in order to understand how much valves limit peak flow, we did this series again about 5 years ago where we took a group of patients who were undergoing TAVI and measured this comprehensive physiology both before and after, including measurements of cardiac output of each stage. And what we showed is that aortic valve area as an index has a fairly weak relationship with reduced peak flow. You can see the scatter dot there, whereas something like the stress aortic valve index provides a much more powerful way of understanding how much peak flow has been limited by the stenotic valve, and therefore how much we stand to gain by doing valve procedures. All right, so we have this new index, the stress aortic valve index. How are we supposed to understand where along this continuum we should think about really abnormal and normal and these trade-offs? And one way of defining the threshold for device therapy is to make measurements before and after you do devices, right? So one of the ways FFR developed its threshold, for example, at the beginning, was to take a series of patients who were undergoing angioplasty, measure it before, after, say, hey, look, it doesn't vary much around 0.74, therefore that can be a device-generated threshold. And we've done something quite similar for SAVI. So we took a group of patients who were having TAVI, measured this before and afterwards, and it turns out that a ratio of about 0.7 then defines aortic stenosis that is of comparable magnitude to patients who've had benefit in clinical trials for TAVI. At the top end of the spectrum, we're recruiting a cohort of patients who are normal and then putting them through invasive dobutamine stress and looking at valve performance. And it turns out that about 0.9 or so or greater is where our normal valves end up functioning. So with that, I'll come to this study. Again, we're doing several studies using SAVI, but this is something called SAVI-AoS, which is looking at the group with moderate aortic stenosis. And as you heard Alan talk about earlier, moderate aortic stenosis is something that actually has a fairly aggressive prognosis. In fact, in some of these series, like the Australian series on the left, a prognosis that's almost as bad as severe aortic stenosis. But it's twice as common, right? So the number of patients out there who have severe aortic stenosis, if you double that, that's a much larger group of patients who have moderate aortic stenosis. And what we're doing in this study is putting them through what I would call a 360-degree valve stress test. So we're taking patients with moderate AS who have an intact ejection fraction and then don't have some alternative explanation for symptoms. It's not as if they have bad coronaries or bad lungs or something like that. And we're measuring SAVI both invasively as well as during bicycle exercise, and then carrying out a whole series of observations in terms of functional assessment, biomarkers, calcium score, that kind of thing. Additionally, we're taking the CTs and then analyzing them using CFD and also printed simulations in order to understand the mechanism, which, as I said before, I think is really related to changing stenosis geometry. Let me contrast two patients in this cohort. On the left-hand side, an 81-year-old woman, and I've listed all of the applicable parameters. And on the right-hand side, an 83-year-old man, and again, I contrast all of the data here. Now, at rest, both of these patients actually appear quite similar, fairly modest pressure loss across the valve. But look at the woman on the left-hand side, right? With dobutamine, a very large increase in the amount of gradient, dropping down to a SAVI of 0.65, something that would be on par with severe aortic stenosis in patients who've been previously studied in randomized trials, whereas on the right-hand side, this gentleman increased his valve flow, but not quite down to those levels. So a SAVI of 0.79, someone that I don't think would benefit from TAVI. And as we're developing this cohort, what we found both in low gradient, which is a paper we published in Structural Heart, as well as in this ongoing study of moderate aortic stenosis, is about half of patients then who are moderate at rest end up having valve severity that's just as comparable as severe aortic stenosis. So this was a review article that was published earlier this year and trying to think about moderate AS. And I'll just highlight a couple features. The first is that people are really enamored with aortic valve area. And I want to emphasize again that this is not a physiologic description of the aortic valve. And this kind of trade-off between functional assessment with something like dobutamine and an anatomic assessment like coronary calcium is a challenge that we've seen in many different areas of cardiology. And I wonder if it just wouldn't be easier to scrap this whole system on the left and simply measure SAVI. Of course, there are limitations, and I've highlighted some here. I'm not going to read through this for you, but it's something that I want to be thoughtful about some of the ways that this might not just be as straightforward as a fractional flow reserve from the coronaries. And at the end of the day, in terms of the moderate AS population, the study that we're leading is really, I would say, a mechanistic study in order to try to understand the role of routine stress testing in a patient population who's symptomatic and has intact ejection fractions, in contrast to some of the ongoing randomized trials in this area that are really using rest testing in order to understand if we should be doing TAVI sooner. Thank you.
Thank you. Any questions for the speakers?
So I had a question about the SAVI. I mean, it's really interesting, and you know, I think it's, I'd never heard the concept before, and so I'm really pleased that I heard it here. I mean, have you, you know, the place to validate this obviously would be in the randomized trials that are ongoing to see if you can measure this and non-invasively pre-procedure and then, or pre, you know, before enrollment, and then see if it stratifies benefit. Have you talked to the companies at all about that possibility? Is there any takers?
Yes, I have talked with them, and as you can see, because about half of the patients are going to have a negative SAVI, the device industry is not very interested in showing that half of the people in the randomized trials probably are not going to have any benefit. And so that has met with not a lot of enthusiasm. And so perhaps the flip side of the coin is the SAVI-AoS trial trying to say that, hey, maybe we should expand indications in moderate, but without you know, going too far. In a way, some of the ongoing trials might be like Courage, right? The kind of studies that at the end of the day say, hey, listen, you know, in an unselected population, we shouldn't be doing this kind of thing, but maybe we can pick out a subgroup where there's benefit.
Well, that's what, I mean, that's what, you know, if the trials end up neutral, it might be a way of, you know, finding the nugget.
Exactly, yeah.
There. So I guess I'm sure you're pretty persuasive. So
I wish otherwise.
It's unfortunate because I mean I do think it would be useful to really understand.
So, question for you is, in the coronary physiology, when you have the anatomy, like you know CT-FFR, people try to measure from anatomy and FFR. The challenge there is that the change in the diameter is not as frequent, you know, it's not as evident.
Right.
Aortic valve, since you can see the motion of the aortic valve, if you integrate the pressure with the motion, you could come up with there are several people working on this, that's why I'm raising this issue, to say that if you can look at the motion of the aortic valve along with the pressure, you could potentially predict that what would happen if you increase the flow without increasing the flow.
Yep.
So
yeah, and that's, for example, I showed that one picture. That's what, so we're collaborating with a colleague of mine who does CFD and fluid structure interaction modeling to try to understand how able we are to take resting CT data and then do kind of a surrogate simulation of increasing, you know, a dobutamine stress test in the CT scanner, if you will, just, you know, empirically, and try to understand what happens to the
because that would be, I think, more easy and practical, just like an IFR would be, or CT-FFR is, that without doing a stress, if you could do the analysis with morphology and motion.
Yeah, I agree with you completely, and that's why we're investigating that. It turns out to be a very hard computational problem in order to understand how leaflet deformity happens, how calcium and thickening of the valve then modifies, you increase flow across it. It's easy conceptually to understand it, but to actually crunch the numbers is a challenging piece. But I agree, that's an important piece.
But you can do this, I mean, the current measurements you're using, you can do it non-invasively. You can give dobutamine to a patient during echocardiography and measure
so part of this study then is twofold. One is that when patients are in the lab for these, we're also then doing an echo, so you can understand how the echo compares to the pressure wire that we have in at the moment. And then also we're pushing patients on a bicycle ergometry to try to understand the trade-offs between exercise and dobutamine. So yeah, this exercise-dobutamine trade-off and invasive, non-invasive trade-off, that's some of the things that we're hoping to learn from this study, so I can come back to you and I say, hey, listen, here's the way we should be measuring this, or at least here are the trade-offs for invasiveness versus imprecision, which is a classic trade-off we have in cardiology all the time.
So I have a question for Professor Yung. Is great talk about upstream management. We discussed pharmacology, etc., but maybe there's value in future with some mechanistic solutions like maybe something like shockwave or to delay when we intervene.
Yeah, I think, you know, to me, it's still kind of a black box. We only detect it when there's aortic stenosis, whether it's mild, moderate, but clearly for decades beforehand, something is going on in that valve. And I think our intervention is way too late. It's because it's replacement, there's no repair going on. So I think by understanding the pathophysiology could be that, let's say, you know, your young people going for a CAC score of the coronary, you look at the valve. If the valve has calcium in it, you should be treating them at that point and see whether that's something that you can prevent. But clearly, you know, at most maybe 10%-ish of the octogenarian get AS. It's not 90%, right? So there's something going on in these, I would say that there's some anatomical issue of these valves. They were born slightly fused, slightly asymmetrical, but we cannot tell, right? Because there's no way to tell. Once you have aortic stenosis that's calcified, everything, all the structure has been destroyed.
Yeah.
So I think that's really, to me, that is interesting. If we have a lot of CTs in a 20-year-old and see who has, you know, measure their valve symmetry, I bet you there's something going on. Even a little bit of fusion, probably, you know, cause you.
So it is very interesting. So about 10 years ago, we did this. So from Cleveland Clinic, we found 80 people who had no aortic stenosis when we did an echo, but transthoracic. And they developed aortic stenosis. And then we found age-matched 80 people who had same no aortic stenosis. And myself and Dr. Jim Thomas, you know, very good echo guy, both of us measured blindly, of course, transthoracic echo. And we came with the same conclusion, that they were not symmetrical in the patients who developed, not fused, but not symmetrical.
Not 120 degrees, a little bit.
Or the size of the leaflets were a little different. And we tried to publish in a better journal, but it's published in, because it's transthoracic echo, so it was not easy to publish in a very good journal. So it is in the Journal of Valvular Heart Disease or something, which the journal is no longer.
Journal doesn't even exist.
Samir, but the problem is there's no solution for it.
No, there is a solution. So solution is what he's saying. Solution is that if you find this patient, you can treat them earlier before you do shockwave. So the shockwave is a done deal. You know, you are already don't have hair.
No. What I mean is you cannot improve symmetry of the valve.
But if you treat the atherosclerosis risk, I think there is a role that these valves get injured.
Exactly.
So therefore, the little turbulence. But if you delay it by 10 years, it's not like you would never have it. So instead of, you know, the person getting at 75, maybe they'll get it 85.
Maybe it's a good thing for bicuspid valves.
So I think there is a value to that.
Yeah. I mean, I think it's also, you know, the LP(a) story is very interesting, and we are on the cusp of having several powerful therapies to reduce LP(a) that might be, again, maybe it's for the bicuspid, but you find if somebody, you know, at age 40 who has a bicuspid valve, and you say, like, let's get you out to, instead of your valve failing at age 65, let's make it fail at 75.
I mean, we can test endothelial function in the coronary, right? How do we tell the endothelial function of the valve? It is kind of slapping around, and then these cells inside doesn't need blood vessel, because it's so thin, supposed to be. So once it's thickened, maybe they are starving, right? Because there's no way to get oxygen anymore. And this cascade go forward. So I think this pathophysiology is just so poorly understood that, you know, by just focusing on the very late stage, which is important, but I think we have lots more work to do.
Has to be way upstream.
Yeah. All right, thank you very much. We're going to turn it over to the next group for the live case, complex PCI. Thank you.
Nice session.